Hello everybody. Today you're going to be listening to a lecture called Nursing Care of the ICU Patient with Pain and Anxiety. There's actually a chapter in your Soul Critical Care Nursing book. I believe it's chapter 5, and it discusses pain, anxiety, and management of such in the intensive care area, more focused. There's also a chapter in IGGY. I believe it's chapter 3. You should have already covered that IGGY content before. It's not as critical care focused, but it's certainly a very good review that you should look into. Okay, so pain anxiety ICU. Before we had ICUs, Nightingale poignantly pointed out that there's a need for adequate ventilation and protection from cruel noise and offensive odors. So before we even got all technical, she realized that patients, it's not just changing their wound dressing. It's not just helping their pneumonia and hydrating them or whatever. The environment they were in also had an effect on how they did. Watson is very aware of that. And also studies show that pain and anxiety is under-recognized and influences each other. They interact and are synergistic. By definition, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or prescribed as such. Look at the lady, we were going in one day, she had horrible neuropathy. We hadn't even touched her legs yet. She was already screaming, oh, oh, oh. For her, it was painful, just the thought of us coming toward her feet. Persistent agitation can prolong hospital stays. Patients that aren't well managed in this way with their pain and anxiety, studies show actually end up in the hospital longer than those that are better managed. Anxiety, by definition, sustained arousal, real or perceived threat, feelings of nervousness or fear, marked by apprehension, agitation, and autonomic arousal. Okay, so it's sustained arousal, real or perceived. So little children, it's very important how we present things to young children, because they'll say no and kind of panic because they don't understand what it's going to be anyway, so it's safer just to say no. So that would be the perceived threat. Marked by apprehension, agitation, and autonomic arousal. I remember my daughter was going in for an immunization shot as a toddler, and the med tech announced she was going to give her a shot. I'm like, no, what are you doing? Just come in the room quickly and quietly. So immediately she started screaming her bloody brains out for the 20 minutes the woman was gone, screaming the whole time while she was prepping. I'm like, really? Then she comes in the room, took 4 of us to hold her down, gives her the shot, and she was, as soon as it was over, she goes, oh, that wasn't so bad. So to her, the perceived threat was huge. The shot wasn't that big of a deal. It stimulates the adrenal cortex to release catecholamines, so vasoconstriction occurs, thus increasing your blood pressure. You're prepping for the threat, so to speak. Good example of anxiety is my son. We're trying to teach him how to drive a standard transmission. For me, I would just get in the car and drive, no big deal, relax. It makes no difference to me whether it's standard or not. It's actually fun. I like doing it. Him, complete panic, he hasn't done it before, he's killing the engine, we're yelling at him. The same activity creates a different arousal. Now, agitation, on the other hand, is excessive, non-purposeful motor activity, inappropriate verbal behavior, or physical aggression. Not so uncommon seeing in the confused ICU patient, somebody that's been medicated, somebody that's been very ill, sometimes in the elderly, and lots of times in the toddlers. Pain, on the other hand, defined by an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And pain is what the patient says it is. And we've gone to huge liberal direction on the pain. It's what's in their head versus the old days, do you really have pain? And we were suspicious that they weren't even having pain. There's probably somewhere in between, but in reality, people perceive pain differently, and some of it's based on their experiences. Good example is the athlete that's just worked out, had a great workout, they feel good about it. They may even, oh, I'm so sore, they're proud of their soreness. They may even stretch, enjoy the soreness a bit. They'll start stretching. A good example, my favorite story is I was caring for two young ladies who were teen pregnancy. So one was, I think they were both 13 years old, if I remember correctly. Very young, 14, 13, I think is what it was. And one of the girls really had no experience with pain, ever, before this. She never had a menstrual period that bothered her. She screamed bloody murder, so much for my laws classes I took with her to help her get through the delivery. But the other young lady had had periods that were such horrible cramps that she had gone to the hospital. Just the pain was horrible and unrelenting. But when she came in pregnancy, the pain was cyclic. It came, she could schedule it, and it went away. So she was very relaxed. So we were literally through the whole delivery. I'm staying up in the middle of the night with her. I remember watching black and white movies, and finally it had been like 6 hours. She goes, I'm feeling a little pressure down there. I'm like, oh, really? Well, the nurse hasn't checked. This was before I was volunteering, so I'm not in the nurse's role here. So, okay, well, let's get the labor and delivery nurse to check you. So she comes in, and she's fully dilated. It was such easy pain compared to her previous pain that she was waiting for the bad pain, and it didn't come. So for her, perception was very different as compared to the other patient. Now the risk, back up a bit, the risk for the agitated patient is certainly burning energy, but the bigger risk we worry about the hospitals are pulling out their ET tube, discontinuing lines, making their wound bleed, anything along those lines that can actually injure themselves or others. So some of the causes of pain, certainly pre-existing disease. The person has a bowel obstruction, appendicitis, cancer, arthritis. Those are just examples. And then the fact you have lines in. Not only do I have the wound for my surgery, but I've got a catheter in or a drain, or I've got a tube in my mouth. I've got suctioning going on. I'm coughing. They're doing a dressing change or pulling tape off. Certainly prolonged immobility. There's plenty of people who they're fine all day if they exercise, they move, and they do things, but laying in a bed in a funny position all day, their back might kill them. What position you're laying in, what kind of bed you're in. And certainly just muscle atrophy. And certainly the individual perception, I kind of gave you that good example, their experiences and their expectations, what they thought was going to happen. It's very important when you're dealing with toddlers and young children. They say not to do the teaching too early because their imagination will build it up into something much, much worse than it actually is. And then they'll throw a huge fit, and then it's not so bad. They find out it's not so bad. So their perception and expectations can alter their view of it. Nociceptive pain is located in the dorsal root ganglia, your peripheral nerve endings. So you can have somatic pain, which is irritation or damage to the nerve system. So one of the classic things is somebody after BKA, they don't, you've had an amputation, right? They'll still have that phantom pain or the phantom feeling, because the nerve endings are going there, of the foot that's no longer there. Or visceral, diffuse, poorly localized, and often referred. That's why they worry about chest pain in some people. It can come across as a lower back pain or down their arm or up in their neck. They don't notice it's actually chest. The Joint Commission got us into the mood now to call pain the fifth vital sign. See, others, because most people, not everybody, but a lot of people in the hospital have some sort of pain scenario. And as you're checking the vital signs, you should also consider that. And back to prolonged immobility, also positioning. I mean, I cannot sleep in the prone position. Once in my life, I slept on my belly because my back was so extremely sunburned, and my neck hurt for 2 weeks. Whereas other people love that position. So you guys, if I'm ever in the hospital, and you're my nurse, and they say, put her in the prone position, that'll help her lungs in some way, don't do it. No, don't do it. She told me in class to never put her in the prone position. Anyway, so your body is designed to have pain to give you message. It's supposed to tell you something's harmful and to pull away for it, to treat it. So it is a medicinal quality that we have to consider. Okay, so a little bit about the ICU environment and assessment. Nurses focus on the person. Our focus is not necessarily the disease, it's the person, which is one of the reasons I went to nursing instead of medicine. The environment interaction influences a person. The environment is a contributing factor to their experience. Certainly things happen. Odors, noise, drugs. I have chronic allergies, so I rarely smell things everybody else smells. One day I was pulled out on the regular floor, and I'd been taking allergy shots, so I was clearly smelling, and I'm like, oh my God, every room bothered me, because normally I don't notice things. Especially like when I do babies. We'd walk in a patient's room, and I wouldn't smell the poopy diaper. Other people would smell it much sooner, so it's a good person. People with allergies probably make better nurses. Anyway, odors, noise. There's no way you can have a quiet ICU if you've got ventilators and pumps going on in a room. Certainly drugs, things are interacting on the patient. Alter communication patterns. Somebody's got a tube in their mouth. Somebody's in pain. Somebody's not their typical person. They may have secondary language issues and they don't have an interpreter handy. All sorts of reasons for that. Pain, we said that. Thirst and hunger, they're a little bit on the miserable side. Temperature changes. Tactile intrusion. I'm not in control of my personal space. I'm not in my own world. I'm in a different place. The geriatric population, this really influences. The little old lady, LOL and NOD, the little old lady in no apparent distress, typically in her own apartment, her own house, she'll be fine. My mother was a good example. She had gotten sick at some point, and my sister-in-law said, oh, we're going to take her to the ER. So she sat in the emergency room. Well, she was married on our chair. She was so confused the whole 3 days she was in the hospital. As soon as she got home, cleared right up. She knew where she was at. She was fine. She was happy. And of course, she has some senility. But in an environment where she was comfortable, she was fine. And a lot of rooms, we just leave the TV on all day. When a patient's room and the TV's blaring all day, it's this noxious, constant stimuli. And for some reason, society has gotten in the habit of constantly having some sort of electronic media. If it's not their cell phone, they're holding on to it, waiting for it to talk to them, or they're looking at their iPad, or they got music playing. Silence is actually medicinal. It's good for you. Lack of sleep is a big problem in the intensive care unit environment. It's not really, I'll joke with patients, they'll complain, I'm in the hospital, I'm so tired, I haven't got any good rest. I'm like, well, you're not here to get rest, you're here to get monitored. Which is true. I'm joking when I say that, but it's a problem in both directions. The patient, when you have lack of sleep, which clearly occurs in the intensive care unit, it's not a normal place to sleep, you're more immunocompromised, you're more likely to be depressed, you're more likely to feel exhaustion, increased pain perception. If you have a good sleep, your pain's not so bad. You're more likely to get confused and be disoriented and agitated. Your circadian cycle is off in the hospital environment because people are coming in and out all day. It's not quiet, the lights aren't out. And the pain itself can lead to lack of sleep. And certainly the design of the ICU is a problem. It used to be worse. Most hospitals have redesigned their ICU since the 80s, but it used to be just open wards with curtains between the beds. And that was purposeful because they wanted to be able to get to everybody quick and see them. But now most units is a glass wall between the beds. You actually have private rooms. That's what's going on. But they need to be surveillance functional. And we need to be able to eyeball the patients so we see them flying out of bed or pulling at their ET tube. And you need to be somewhat close to them. So yet now we try to give them some privacy with like little walls, not just curtains. Certainly the monitoring equipment is designed to make noise and to yell at us. And even if you don't want to make noise, it's still humming along, making some noise. Ventilators have noise. Continuous lighting. We have to be able to see what's going on in the room. And sink in the room, you're running water. Things are making noises. And people just walking in the hallway, doing what they need to do. Calling somebody, asking for help in the ICU might wake somebody up. Okay, so what else do we assess? This environment leads to patients having an altered perception of time and space. There's small spaces, they're busy, patients need rest. So usually you'll try to think when you're taking care of this patient, what am I doing? Have I given them a break? What's going on with this patient? ICU is an unconducive family visiting environment. It's really not set up for that, even though we encourage now families to be there most of the time or as much as they want to. It's really not a pleasant place for that. It's designed to be given critical care, nursing care. Families are in a way a lot of times, and they feel helpless, and certainly they're more commonly than not afraid of the equipment as well. So they're scared of their own family member and what's going on with them, which adds to the room anxiety. There's lack of space. We don't want this huge, giant, comfortable area with extra bed room in it. We need to be able to get quickly to our patients. So we don't want it down the long hallway where there's some privacy. And there's almost always some sort of conversation going on in the ICU or at the bedside. Patient might be in a coma, have increased ICP, so we want them quiet and calm and not so noisy. And certainly you need to be culturally sensitive, identify unusual, what you consider unusual responses to illness or pain, and certainly provide religious support. People handle things differently. I remember one year we had a woman of a particular ethnic background, and she was incredibly histrionic. I mean, she was wailing at the loss of this child, that literally dragging on the floor with family members. And I remember a lot of nurses were like, oh my God, we're offended. But realize, well, where she's from, that's the expectation. And we're supposed to be stern and tough and withhold and control our crying. So it's a different culture, and you need to be responsive to that. Patients lose personal control. They're at the mercy and the mood and control of the caregivers. I tell you when to turn. I tell you when you get in the chair. I tell you when it's time to suction you. I tell you when it's time to do your dressing. That's the cool part about being a nurse. You're really managing the patient, but they have no personal control. Anyway, so here's a little graphic here. I believe there's a version of this in your textbook. So what happens? Look at all the interaction here. Kind of just went over it, but pre-admission, psychological state's important. What did you come in with in the first place? How good could it get? If you took my senile mother in to the hospital, my expectations were low in the first place. All she's going to do is be more agitated. What kind of interpersonal relationships? Does this person have family support? Are they stressed out because they were the big caregiver at home and now they can't? Or they used to being cared for and so they're okay? What's the psychopathology that the patient may have? Is this person been depressed for years? Are they manic depressive? Are they are they one of those control? Are they control freak normally in their life? So this is terrible. They're not in control. Do they have underlying anxiety, or are they just anxiety over the situation? What are their normal coping strategies when stress occurs? What's the perception of the meaning of the illness to them? If I'm going into surgery for plastic surgery, let's say, and I think this is a great thing, and I'm imagining my life's only going to be better somehow, versus somebody with a diagnosis of cancer, and we don't know if it's stage 4, these people are coming in with a totally different attitude. Age of the individual leads to experience, leads to expectations. We're always different when it's a young person that's very, very ill. We feel so much more sympathy and empathy and worry about it. We work harder in a way. We'll prolong the care on that younger person versus an 80-year-old. We're like, woo, you made it. You had a good life. Let's just make it not your way out the door not so bad. We tend to look at them slightly differently. What's the disease? Why are they there? What's going on? This influences on anxiety, sleep, and psychoses. Then certainly psychological disturbances like pain, fever, hypoxia, hypertension, the surgery, whatever they had done, let's say, whatever procedures, any drugs they're on, if they've been kept up all night, insomnia, and any communication barriers adds to anxiety, no sleep, and psychoses. Then go to the other side. What room are we in? What's the environment? Are they close to the nurse's station? Are they far from the nurse's station? Do they have any privacy? Are there windows, pleasant windows they can look outside? Is it lit all the time? Is it noisy? Is there monotony? Are they just bored to tears? Are they restrained? Is there a lot of equipment going on? And then certainly staff. Are we preoccupied with equipment? Is this somebody that I can actually leave alone and let them sleep? Or is there a bunch of stuff I need to do, procedures, monitoring in the room? Is there a high stress level? Is somebody that they're recovering and want to relax, or they're unstable? Do we have unguarded conversation? My worst story, and it's a good story, I guess, too. Years ago, we had a guy, and I'll tell this one again because he was a very interesting case. I'll throw it up in other stories probably, but it was an ultraflying plane accident, and he was not moving and not responsive. And the neurosurgeon, of course, knew more than we had. He'd seen the CAT scans, and he said this guy had a noxic brain injury. So he was with it completely, but he had no motor control. And as he's explained this to us, the nurses, and the resident in the room, tears started coming out of the guy's eyes. And I'm like, oh my God. He knew and understood everything we were saying. He just couldn't move. Eventually, he was able to tap a foot, wiggle a finger. Everything got better over time. But this was unguarded conversation. Actually, maybe it wasn't so unguarded on the part of the surgeon. He was explaining to the patient, too. That's certainly inexperienced physicians that sometimes we're dealing with residents and they don't have as good a grasp on the big picture. So what are some of the potential problems? Potential problems with we call it ICU-itis. It is, I say here, but ICU-itis is what nurses will call it. Agitation. What happens? Increased heart rate, increased respiratory rate, certainly increased work of the myocardium. So if somebody, sometimes, and we'll talk about this later, patients in the intensive care unit, we sedate and we paralyze literally just to take away the work of breathing and the work for their heart. So when you're excited, you are burning more energy. It certainly increases the intracranial pressure, which is a problem for some patients. If they pull out lines, that's a problem. Now we don't have a line. If they fall out of bed, and certainly all of this leads to increased costs. If paranoid or hallucinogenic, you try to leave them unrestrained as much as possible. Pulling and jerking on lines increases the paranoia and the agitation. Funny story years ago, the neurosurgeon's patients obviously a lot of times were out of it and restless and wild, but we're trying to get them to recover from surgery. So they're dangerous, right? So we would always have to restrain them in some way. But he didn't want the arms restrained on any of his patients. Never restrained their arms because he felt if they were pulling, which is a truism, it would increase their intracranial pressure. So we would always mitt their hands. We put a wash rag in and Kerlix around. It was great. They could flail around, but they were mitted. So this one lady was particularly restless. And so one of the nurses tied her down as well as had a restraint on her. And he yelled, and he said, no, you can't restrain her, just posy her. So it was kind of comical because you could see in her room. And we were standing at the nurse's station arguing with him that no, you can still hurt yourself. Because we had her posied, her chest to the bed, her arms could flail, but she could flail around. And we're literally having the conversation. He's like, no, they can't fall in bed, they won't hurt themselves. And at that time, she flipped her legs over the railing, and her butt was just staring at us, and she was peeing on the floor. And so her chest was still tied to the bed, but her whole lower torso was hanging out of the bed. And we were just, you mean like that, Dr. Lynch? I mean, it was something you would put in a movie, because it literally, bam, happened on key. Anyway, so it's a problem. The unstable, the unconfused patient, how do you manage them without further restraining them? Fear and anxiety can worsen physiological instability, and literally there's no perfect pain scale for patients if they can't communicate. I got a confused patient. What's your pain on a scale of 1 to 10? Which was your earlier lectures. Or which smiley face do you prefer? And you're supposed to point. They're confused. And you might just get cussed out by some of them. And here's a observational tool, another way to attempt to scale and measure theoretically pain, which might just be agitation in a given patient. But look at facial expressions. There's an example of this in your book. You don't have to write this all down, but facial expressions, relaxed, no muscle tension, to grimacing. Okay, so you give it a scale. Body movements. Is there nothing going on? Restless, or they're restless? This is assuming somebody's confused, not just tapping to the music in the room, right? Muscle tension, upper extremity, do they seem relaxed, or are they very tense and rigid? Compliance with the ventilator, are they fighting the ventilator, or are they relaxed? And certainly non-ventilator patient vocalization, what's going on? Now, crying and sobbing, and I don't think this is a good tool because a lot of confused patients aren't crying and sobbing, but they're still confused. People in pain don't always cry, but they had to come up with some sort of tool. And you can argue a lot of these points, but it's some way to kind of get an assessment to document, do I need to treat this patient for pain? Now, a few more definitions here. Delirium is, by definition, a reversible, organic mental impairment, fragmented thoughts, inattention, disorganized attention and thinking, or altered level of consciousness. Not considered a psychiatric diagnosis. So delirium, I've got something going on, a bunch of medications in the hospital, I'm septic, whatever reason, I have my delirium. Okay? So I'm not underlying manic depressive, I'm septic. So some sort of acute brain dysfunction. Acute meaning episodic now. ICU psychosis is the term we throw out there, you'll see the nurses use it, is delirium, or you'll see nurses say he has sundown syndrome, or ICU syndrome. These are all words you'll see people throwing out there. Delusions and nightmares. They may have space disorientation. A good one was the example of my mother. As long as she's in her environment, she wasn't confused. You took her out to the emergency room and put her somewhere else. Her senility really made her much more a sundowner syndrome or ICU psychosis type person. They distorted or paranoid ideas. For example, I had a guy in the burn center. He'd been in the burn center for a couple of weeks. He'd been very critically ill. And he was kind of not quite, we were probably going to send him to the floor the next day, quite not ready for the floor. And I had him in the morning, and he was like, there's spiders. There's spiders over in that corner. What are all those spiders doing over there? Can you get the spider? I'm like, oh my God, he's getting ICU-itis or ICU psychosis. So they came up here lucid. He was having a nice conversation to me. He was making sense. And then he'd revert to this irritated agitation about the spiders in the corner, and it was driving him crazy. And so I was fearful he'd get more aggressive. So what did I do? I put him in the wheelchair, and I rode him up and down the hallway twice just to get him out of the room he'd been in for weeks, the four same walls. He needed something else. He was getting ICU psychosis. He was getting delirium. And it calmed down. I got him out of the room a couple times that day, tried to get something going on for him. And it improved it immediately. One of the cutest things, I had a little girl and the cath lab, was in the recovery room in the cath lab. And of course they were sedated, right? So we had the little television that pull it right in front of their faces. So we put the little cartoons on for her because we don't want them kicking and screaming or they'll bleed again. And she was so cute. She's looking at the cartoon and she goes, 2 elephants. I see 2 elephants. 2 pigs. Because whatever the cartoon was on, she was obviously cross-eyed and seeing double of everything. It was obviously very cute, but she wasn't over her medication yet. And she was very sweet, so she wasn't combative. Psychosis is persistence with a disease. So when we say ICU psychosis, we're actually misusing the word. So if you say ICU-itis, somehow I'm misspelling that, I'm sure. Really, it's just a label we give, and we mean delirium. But you'll see nurses use it all the time. Now, do not confuse your patient's confusion with alcohol withdrawal. Then you're both confused. Okay? So, especially with this older generation, actually, alcoholism hits every age. Something about South Orange County. I mean, I've worked in Oklahoma, I worked in West LA, I worked in Long Beach, I've worked a lot of different places, different clinicals with students, staff nursing, and the most alcoholism I've seen is in South Orange County. And I commented to some nurse one day, I'm like, oh my God, my students, we had 3 patients in on the same shift. 2 of them with severe alcohol withdrawals, 1 with liver failure from his alcoholism, and they weren't, the one guy was like some wealthy businessman. He was probably only in his, I remember correctly, like 44. And the other two were completely in severe alcohol withdrawals. She said, they're just bored. They've got money, they bought their house in the 70s, now it's worth millions, and they just drink. I'm like, wow, okay, they need to start doing some volunteer work, something else. Anyway, so what are you looking for? If my dad went to the hospital today, who has a cocktail every single night, he's never been drunk, he doesn't drink all day, he never binges, but he has to have that really stiff drink. So it's probably like 4 shots of whiskey every night. If he went to the hospital, he would have alcohol withdrawals. So you need to monitor for that in patients. It's fairly common. What happens, they start hallucinating, they'll get agitated, they might be diaphoretic, tachycardic, and they risk seizures. Usually 6 to 12 hours after the last drink. So if you had your drink in the evening, by the next night you could see problems. Sometimes days later. Treatment is typically Librium. It's amazing how that's your answer. If Librium works, you probably saw an alcoholic. But definitely think about that in many patients coming in. And now we have so many people doing drugs as well, they'll have withdrawals. So what are the risk factors? Who's at risk for being confused and your patient in the ICU? Certainly acuteness of the illness. Somebody's sicker, certainly more dangerous to have metabolic issues. Older than 70. Been in a nursing home. There's a reason they were in the nursing home in the first place. Don't assume they're going to be clear as a bell coming into you. If there's a history of dementia, depression, or stroke, the same sweet guy that was sweet guys for years after a stroke can have an affect change. Alcohol or substance abuse history. Ask those questions. Is he a drinker? Does he do drugs? I have a friend at my kid's school, nice looking guy, he works full time, and I was talking to my wife one day, she goes, he smokes pot every day. I'm like, and he's got heart failure from his alcohol. I'm like, he's only in his 40s. I'm like, I've never seen the guy drunk, I've never seen him drink. So here's a guy that looks like a normal father of 3, active person in the school, coaching the baseball team, and he's got issues. So don't assume somebody dressed well, looking good, is an alcoholic or a substance abuser. Certainly electrolyte imbalances, fever situation, hypothermia, certainly renal or liver failure because of metabolites can cause issues, somebody in shock, poor perfusion state, HIV, other infection states as well, multiple tubes and lines. Multiple lines don't cause you delirium, but certainly that means they're sicker if they have more stuff going on. So the risk, you assume mentally they might have instability as well. Poor nutritional status. Oh my gosh, these poor patients are in the hospital for days and weeks and months, or poor nutrition before they even came in. Needing restraints, visually or hearing impaired or language barrier. All reasons to be agitated or anxious or confused. Now, some of the things. Sensory alterations from pain and immobilization reported by patients crippling. Because this is a study. This was Ballard and Wilson's study, and they looked at sensory overload and deprivation. So it's kind of a nice list I thought I'd share with you. And the ones that they were not confused by the time they came out, so they could explain this. Being tied down by tubes. So even though your arms aren't restrained, you can't just get up and walk around. You've got like a chest tube. You're not able to move freely. Being in pain, being thirsty, being on a ventilator, having to wear an oxygen mask. Frequent interruptions of sleep. God help the person when I'm trying to sleep and they come in and take my dang blood pressure. That's not going to be pretty. Missing your spouse. You're missing your spouse or your children, if that means. Seeing family and friends minimally. Not being able to sleep because you're in a strange bed. You're in a strange place. Some people need to sleep with their pillow and their own little blankie in their own little world. Having too many tubes. Not knowing what to expect. When to expect things will be done to you. What's next? Losing track of time, having doctors and nursing talking about you rather than to you. One of the things I got a degree of kudos for, I used to do all the pre-heart surgery and pre-catheterization teaching for all the children at when I was a clinical specialist at Cedars-Sinai. Well, when I gave the tours, I'd give them a tour of the cath lab recovery area and kind of go over stuff with them. I always talk to the child. Even though what I was telling was really for the parents, I talked to the child. Everything was meant at their level. I remember this one kid goes, I really like you. You're great. I'm like, really? Oh, well, I appreciate it. He goes, yeah. He goes, you say things like cool and stuff. I was trying to say it at his level, and he clearly saw that. You weren't talking over him. I was talking to him. Too much noise. Having no privacy. People just come in. Excuse me, sir. I need you to have this enema for your procedure. I mean, really, a horrible thing to tell somebody. Too much light. You need a nice, cozy, dark room to sleep. And these are just some of the nursing diagnoses. I'm sure you could open your NANDA book and come up with more. But certainly fear. No, don't forget, when you're dialing these things up, related to and as evidenced by. Just on this lecture, related to tubes and lines, a strange place, dehydrated. You can come up with them. For any of these diagnoses, you should have multiple related to. Then as evidenced by, patients anxious, heart rate's up. You would have a list of as evidenced by. Patient said this, family said that. Anxiety, knowledge deficit, adjustment impaired, diversional activity deficit, hopelessness, self-care deficit, self-concept, self-perceptual alteration, sleep pattern disturbance, social interaction impaired, social isolation, thought process alteration, communication altered. Now that can be a variety of things, language barriers, tube in your mouth, or the drugs you're on. Alteration in comfort, pain, activity intolerance, coping ineffective, grieving, and powerlessness. That's a huge list, and you could probably come up with more. So what are the nursing goals for these patients? Nursing goal is to manipulate the environment for the benefit of the patient, which leads to positive outcome. Okay, that sounds good. What do we do? Increase comfort. We may induce amnesia, depending on what meds we're using, with the lowest dose possible. One of the big problems with some of the drugs that are getting more passé now is, yes, it was great, it made them feel great, and they were quickly addicted. So you want to do what you can do, and you want them functional. Part of the comfort is, let's talk about a kid. Okay, if I have a child after open heart surgery, I'm the notorious mean person. I was a nurse specialist, right? So the kid's laying in bed and just scared by the time he got to the floor. And the nurses would invariably leave him alone because they were scared of him too. I'm like, no, give him a pain med, I'll be back in 20 minutes. Now, pain med in kids is generally just Tylenol. Yes, their chest was sawed open, but they don't need to be groggy. They need to get up and play. And I've been one dragging the kid crying down the hallway. Dragging him down the hallway and throw him in the playroom. Come back 20 minutes later, they're happy as a bug in a rug. So a lot of their pain, not all their pain, but a lot of their pain was fear and just petrified. Look what happened to them. They had open heart surgery. And once they get their confidence back up again, and they've got some Tylenol also for help the general aches and pains, these children were happily playing in the playroom. Literally. But you had to push them to get them over the hump. Your job is to keep the patient safe. So as much as I don't want to sedate somebody too much, I also can't have them pulling out their ET tube, right? And pulling all their lines out. Assist in ventilator management, hemodynamic stability. Sometimes we'll sedate heavily for hemodynamic stability. Minimize stressors and anxiety as much as possible, and medicate if and when necessary. So nursing interventions. Get that drinking and drug history. Know what's coming in the door. Know what I'm seeing in the first place. Why would I expect a little old lady that's been senile at home to suddenly actually cooperate? Provide teaching information. Lack of knowledge leads to fear and confusion. Children that knew, here's the best example, adults. If I would go see a patient, do pre-op teaching before open heart surgery, and I'd warn them there's going to be a tube in your mouth, they would do so much better in the post-recovery, in the ICU. So I'd have patients wake up, and you can see they're in a panic. They're waking up from heart surgery, there's a tube in their nose, their mouth, they got chest tubes, art lines, Foley's, their chest has been opened, the room is noisy, and they're confused. And I can see them panicking, their heart rate's jumping up, their blood pressure's jumping up, which I don't want the vessel to burst, so I need to manage that. I'll whisper in their ear, sir, there's a tube in your mouth. It feels terrible and you can't talk, but that's normal. And you see them relax. And sometimes you don't say that. If you just say, calm down, you need to relax, we need to keep that tube in your mouth, they keep panicking because they think, no, this doesn't feel right. This can't be right, and you don't understand, this feels terrible. But if I tell them, it feels terrible, but that's normal, it's okay, literally, they'll calm down. So your knowledge, what you're telling them, you have to be careful, right? Prepare a patient before pre-op teaching. We'll walk the kids through the ICU, see where they're going to be, go over the tubes and line, explain what they're going to expect. Progress patient forward as soon as possible. Don't just leave them languishing because we can monitor them. Get people out of bed, move them forward. Consider drug interactions. What am I giving? Is this too much? Preemptively treat pain before it escalates. And you should all have already had a lecture on that one. Relaxation techniques. Take a deep breath, calm down, relax. People do so much better. And certainly be culturally sensitive. Identify unusual responses to illness and provide religious support, which we mentioned earlier, which is very important. People look at things differently. Talk to the patient. Try to get an assessment of their orientation. All right, so what are other interventions for the ambiance? What can we do? Manage rest periods with visitors and treatment. So I've got family all wants to come and visit. Okay, well, you know what? He has now a nap. He needs rest. He needs a break. Everybody go to lunch. Get out of the room. Do those sort of things. If possible, try to schedule at least 2-hour breaks. Lump your procedures. Have visitors come in during meals. He's going to be sitting up anyway. Encourage therapeutic family interactions. Good example is, you'll see this a lot with the men and the women. The guy had heart surgery, and the woman's spoon feeding him. Like, no. He needs to feed himself. He needs to use his arm. Even though he's enjoying sitting there being the puppy dog and being waited on, you want therapeutic family interactions. We need you to encourage him to feed himself. Comfort measures, such as a soothing voice, sweet talk, foster trust. Talk to patient rather than about him, and constantly be assessing for their orientation. You want a good established communication links. Sometimes it's a name board. Sometimes it's a pen and paper. They're trying to write you a note. We had a guy that knew Morse code, and all he could do was move his foot. So we had a Morse code board on the wall. And then we also had a yes and no blinking thing, because he could blink and tap his foot. So we had a blinking system and a Morse code system. This is that same guy that was paralyzed. One day I was changing out his rotor-rest bed, and we were changing the pads, and we were doing stuff, and he just started blinking like crazy, because that's all I could do. Blinking like crazy. I couldn't figure out what was wrong. I was trying to get him to spell something out. Finally realized his thumb was smashed in between, because he could feel. He just couldn't move. It was smashed between the little bed bump things. I'm like, oh my God. It took me a while to figure it out. Poor guy. Just blinking, blinking, blinking in a panic. Encourage some control, like the wiping the patient. He needs to do it. Wipe your own crotch. Our patient's, okay, I'm going to give you your bath. Now here's a wash rag. You wipe down there. Give them a little privacy. Suction out mouth with the Yonkers. One of my favorite things to do with patients on the ventilator is get the Yonkers tube, the oral suction thing, and put it in their hand. So they can sit and play and suction their own mouth out, giving them some control. This obviously has to be the oriented patient intubated. It's great. You can see patients so happy they can actually get to do something. Think about yourself at the dentist. You're sitting there trying to swallow. If you had a little tube and you could do it yourself, wouldn't that be nice? Anyway, earphones, that's a common thing we'll do for music. If the patient likes music, a lot of times you'll see people use that for cath lab procedures, that sort of thing. Other things we can do in the room, minimize noise as possible. You'll see some nurses' stations have these meters up. The light goes yellow and red if we're getting too noisy at the nurses' station. Put the stable cognitive patients further away from the desk, and the confused patients you need to watch closer to the nurses' station. So you'll see a lot of bed shifting going on some of the floors just for these kinds of reasons. Oh yeah, he's gotten all confused. We've got to move him closer. Most rooms will have clocks and calendars to help people get oriented. You'll see the marker boards where the nurses put their names and the date. Change the patient's position. Sometimes you just move the bed around so they can look out the window better. Open the curtains. Let the light in during the day and close them when it's bedtime. Minimize the lighting and noise at night. Alarms away from the patient's ears as much as possible. Individual thermostats. Depending on the room, you may be able to control the thermostat in the room. Pictures from home taped on the walls. Bring in pictures of the children and the family member. And certainly frequently reorienting the individual. Okay, so use of a sedation scale. Some of the things we do, we need to monitor where they're at and assess it and write it down. So numeric sort of scales are useful. One of the scales is a Ramsey scale. You'll see that in your book. 1 through 5, awake. It's awake to sleep scale. It's a way for you to chart where they're at. There's another Riker scale, agitation scale. Levels 1 through 7 from dangerous, agitation, down right to unresponsive. So it's a numeric, to give a numeric quality to what you're assessing. The other one is an observer assessment of alertness sedation scale, literally just another scale, levels 1 to 5 responsive, looks at speech, looks at facial expression, looks at eyes. Depending on where you work, they may have these in their computer system and what you're supposed to chart as part of your sedation system. If not, it's really important for you to describe, use your medical vocabulary, and describe patient's obtundant, blah, 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 blah. What are you going to describe about him? And then, now we have actual drugs, okay? So sometimes we'll use neuromuscular blocking agents. These are drugs used to induce acute skeletal muscle relaxation and paralysis. Now, why? For facilitation of intubation. Okay, I didn't tell you this story, but it did happen. We had a guy, the patient was wild and restless, very short of breath. We needed to intubate him. We needed to get a chest tube in, but he was severely combative. Well, he was confused, and his oxygen level was dropping. So, of course, he got more agitated, more combative, the more his oxygen level dropped, right? So it's very difficult. We did have a line, an IV line in, and we couldn't get the chest tube in, we couldn't get him intubated. So the anesthesia, we called anesthesia, we need help. So he paralyzed the guy. Then he chewed him out. This was a very confident anesthesiologist. Chewed him out a bit before he intubated him. You need to cooperate these. I'm like, oh my God. And we're all like looking at each other, just intubate him. But he chewed the guy out for being restless and fighting everybody, intubated him, ventilated him, and then we got the chest tube in. So we paralyzed him, literally, so we could do these procedures. Why? Sometimes acute lung injury, respiratory management, to stabilize the lungs so we can give them care. To decrease intracranial pressure. I think I probably already told you, we've seen this more than once. We'll sedate a patient as much as we can because they are so wild and restless, they're just making their numbers go up. Hemodynamically unstable. So sometimes it's respiratory instability, sometimes it's hemodynamic blood pressure-wise. And you can stabilize and better manage it sometimes when they're sedated and paralyzed. To decrease oxygen consumption, so not burning the candle at both ends. And to control the ventilator. They're bucking, they're fighting, and now you can actually ventilate them and get good oxygenation. Patho-wise, it interferes with neuromuscular transmission, so they're paralyzed, but they're conscious. So you're not treating their pain, you're not making them sleep. They are literally just paralyzed. They won't breathe. So you have to breathe for them. I think I get into this. We'll get into another minute. Okay, so what's understanding care of these patients? You risk that you induce paralysis but no sedation. So the sensation is intact. So they can't move with these neuroblocking agents, but they can feel pain. Okay? So that's terrible. So sometimes in the OR, they're going to do both because you can't have people wiggling around on the OR field, right? So they'll paralyze them and they'll sedate them. But I can think of twice in my career that they got paralyzed and not sedated, or the sedation wasn't good enough in some way. So we had this lady in the ICU, she had open heart surgery, and this happened twice. But I remember I was there for this one when the surgeon came up, and she was able to say everything they were talking about, what was on the radio, and she described what was going on in surgery. Um, we freaked out. We had to get a psych consult for her, but she was just sort of it was this weird fugue state. She wasn't psychotic about it. She could just describe it. So she said, and then studies show they don't know whether they're dead or alive. They don't know what's going on, but they know that they can't move. It's hard to panic when you can't move, but they know they can hear everything that's going on. So you have to balance that sedation with the paralysis. So the other thing to watch for when you're sedating heavily patients or paralyzed patients is skin and eye care. They can't twist and move to reposition themselves, right? The eyes don't always shut all the way, so you'll see eyes shut, or we're using tears or the lubricant. This is really important. It was a problem because most all the children were sedated and paralyzed that we care for in the cardiovascular ICU because they had major open heart surgery, and no 2-year-old's going to sit still for it, right? So, and they were very sick. They'd be sick for days. So part of the hemodynamic stability was the sedation. And we had to get a lecture from the Eye Institute because they kept getting our kids because they have corneal abrasion issues from it drying out. So normally you blink and you protect your eyes or they're shut. But if they're relaxed, they're not shut all the way. And so you really have to monitor it on these patients. Generally, you can tube feed them because they're only the striatal muscles are affected. But you need meticulous pulmonary, what we call pulmonary toilet, to make sure they're able to cough, and because they can't cough, so you clear the secretions. And then you can see a little picture here. There's a peripheral nerve stimulator, so it's a way to know where they're at and if their dosage is correct. At the ulnar, the thumb, it's like a little shock thing. It gives you, it's a way to monitor the degree of paralysis and to guide your drug titration. And so, and minimal prolonged muscle weakness post-use, basically. So anyway, so at the ulnar, thumb twitch. If you do it 4 times, watch only 1 of the 4 should twitch, or you need more medicine. It's a way to easily at the bedside check your neuromuscular blocking that's going on. Common neuromuscular blocking agents basically all have a rapid onset. You'll see them called, this one succinylcholine. People just call it suck because it's too hard to say. IV push, short acting. Pavilon, IV push, same thing, short acting, all rapid onset. Pavilon's common. Vecuronium, you'll see people call it VEC. IV push or drip, initially 0.1 micrograms per kilogram per minute, and then you follow with the drip. Usually maintain continuous neuroblast. So top 2 common in the OR, common Pavilon if you're just intubating somebody. You might see a VEC drip for somebody that's going to stay in the ICU on these need to be paralyzed. Adjust the infusion rate to maintain 90% of neuromuscular blocking. These are given with sedatives, commonly fentanyl and morphine. So you may have a patient on a VEC drip and a fentanyl drip at the same time. So what do? There's a way to reverse neuromuscular blocking agents. Prostigmine is an IV push slow. If you, let's say you just intubated somebody, for some reason you need to wake them up and reverse it. Watch your bedside conversation. Just because they can't move and they can't respond doesn't mean they don't hear. Use your touch and words of encouragement. Frequently reorient the person to what's going on. There's a study by Johnson, interviewed patients, status post-paralysis and sedation. If they remember, they can't talk, see, move, they don't know whether they were alive or dead, disoriented sense of reality. I had a little bit of this. When I had my first baby, it was an emergency, and they gave me an epidural, and I was septic, so it was an emergency. They weren't going to stop. And I felt it go down one leg and not the other. So I could feel the whole delivery, the C-section, but it didn't hurt so much as I could feel it. So I could say, okay, now you're cutting. Okay, now you're pulling. Now you pull my uterus out. I was giving them a blow-by-blow of what they were doing. But they didn't want to sedate me till she was out. And so, but I wanted to let them know to hurry up because I know exactly what they're doing. I was like, that went down one leg, not the other one. They just flipped me over and just kept going. Okay, now you're cutting. It was sort of this numb feeling when I could still feel it. So I can imagine a little bit what these people go through if it didn't get proper coverage. So what about pain management? Okay, we got them paralyzed. Now how are we going to sedate them? Oh, I have a picture over here. Oh, well. Anyway, opiates, typically morphine, fentanyl, hydromorph have been popular. The effects are analgesia. You should have had this over in Farm, but we're going to go through it here just a bit. Euphoria, sedation, amnesia, sedation for anti-anxiety as well. What are the side effects? Hypotension, from vasodilation, decreased respiratory rate, decreased GI motility, hallucination, agitation. So these are people you watch for, am I just making them confused and we're not really helping the pain? And certainly the Tylenol with codeine people that take it, for a week post-op invariably will complain about constipation. Dilaudid as what is your hydromorphone. And Demerol was big in the 80s and maybe early 90s and sort of lost its market to other drugs. More sedatives. Benzodiazepines, the Valiums, the Verseds. Again, you should have had this in Farm Lab, so I'm just reviewing. Ativan and Librium. What do we get? Effects, sedation. Amylox, remember, sedation, anti-anxiety. Lost my spot. Okay, so sedation, anti-anxiotic, amnesia, muscle relaxant, and anticonvulsants. So they follow under these categories. Not as an analgesic necessarily. So we're not necessarily helping your pain. We're helping you maybe not care. Relaxing. A little non-memory. Some of the side effects, it's thought to be okay for sleep cycles, okay for respiratory and blood pressure, fewer side effects. It does accumulate in the fat and has to be metabolized over days, so it's not gone quickly. There's withdrawal problems. It can lead to anxiety and agitation and even seizures. So you gradually withdraw some of these. Propofol, very popular for the anesthesiologist, general anesthesia, but at lower doses, it's a sedative. You won't see that used so much on the floor. And then dexamethasone for short-term sedatives. I'm trying to think of some good examples. We did have kind of a comical one. We had a girl that was ventilator anesthesia, and she was obese, and she was in a car accident. And I remember because the family is like, we got to get in there. We have to get in there. We have to pray for her. She's going to want to see her baby. And the family was just very pushy. There were a lot of them. They were just pushing. Like, she's not even out of surgery yet. You got to wait out here, blah, blah, blah. We get her in the room. And it's this very Christian family. She has to be prayed. We have to be there for her. Well, then we get in the room, and the girl is just cussing us all out of the blue stream. Never asked to see her child. We're like, oh. The story the parents was telling it, the family was telling us, didn't match the teenager. I remember because we kept leaning over her bed. She was an orthopedic issue, and one nurse started getting dizzy and had to go sit down. And we're like, what's wrong with you? She goes, I don't know. Oh, so we thought it was her. Then the next nurse went down, was trying to talk to her because she was whispering. So she was exhaling anesthesia, and the nurse caring for her was getting breathed upon, and two people got dizzy taking care of this young lady. And but she was obese, so it's slowly coming out. So one of the things you worry about on those patients is they'll wake them up in the recovery area or in the OR, and then they send them to your ICU or to the floor, and then it comes out of the tissue and they get sleepy again. So you've got to watch them over a time period. You don't just say, oh, it's over, and send them home, right? Fentanyl drips are very popular for children to manage them because it's a continuous drip type of thing. What else? Neuroleptics, Haldol to treat delirium. It sedates with little respiratory depression. but usually this is the used for the confused, combative, alcoholic crowd. It's antipsychosis, decreased hallucinations, paranoia, decreases blood pressure, and arrhythmia risk. If you have a history of alcohol or drug abuse, anybody with history of alcohol or drug abuse, you worry that they're going to need a higher threshold before pain meds will help them. My favorite example, I had a guy up at UCLA that had heart surgery, and he was a makeup artist, for movies and stuff, and he'd been basically a partier for years, and he had this ridiculously high pain threshold. I gave him morphine, and he didn't bat an eye. But they'd warned us he was a long-standing history of drug abuse. And those people have a higher morbidity and mortality rate as well. So you need to be more sensitive and certainly more fretful and worry about them a little bit more. Okay, so just example of a care plan here to close out this lecture. My example is Mrs. J, who's a 68-year-old female with COPD. She has been at a home on O2 when was recently admitted with shortness of breath and pneumonia. She respiratory arrested on the floor and was intubated and transferred to the ICU. So you have somebody that had been at home, chronically ill, all respiratory issues, and now is in the ICU with a tube in her mouth. Okay, so my nursing diagnosis would be anxiety related to the ET tube gagging and a communication barrier. The emergency circumstances, so no teaching pre the tube, she didn't know what's going on. Certainly she's fearful that she's near death because she knows long-term COPD is not a good diagnosis. She's struggling to breathe. She's in a strange room in a noisy ventilator, and large variety of caretakers. So she has a lot of related to be anxious. My assessment was she's tachycardia, she's restless, she's pointing at the ET tube, trying to mouth words, she's diaphoretic. Her ABGs on the ventilator are abnormal, but within her normal range, so we're at least able to ventilate her. Interventions-wise, I'll try to explain all the procedures. I might give her, if she can handle it, the oral Yonkers tube so she can suction her own mouth if she's coherent enough. I may sedate her every 2 to 4 hours with Ativan, 2 milligrams IV was my order. Monitor response to the medication. Does this even help? How good is it? Maybe she only needs 1 milligram. Position her comfortably, get her head up a little bit, make her comfortable. Encourage visitors that know her and can help her relax a little bit and involve them in the care if they're interested, if they can handle it. Remember, you don't want the person adding to her anxiety or stress. And certainly provide quiet rest time immediately after I medicated her so she can get a break. So that's just one example of what you might write up on a particular patient. So this is an overview. I know you had in Pharm Lab some of those meds. You should have heard them already. And certainly you talked about pain management. This is just to kind of give you the ICU twist. And thanks for listening, and we'll see you in class.